Good morning, everybody. Welcome to the Manipal Talk. We'll be following up on cervical precancers, and like in previous class, I had told you the FOXY guidelines of um, screening, direct treatment, screen, test, treat. So now we come to the treatment part. Okay, or approach to according to all the screening modalities of pap smear, HPV DNA, VIA. How are you going to treat? How are you going to, based on what findings, how are you going to go about it? So in pap smear, like I told you, you can get ascus, undetermined atypical squamous cells of undetermined significance. You can get LSIL, you can get ascus H, and you can get HSIL. So all of this I have told you in the previous video. If you want, please follow back on it. Here we will just be keeping it very simple because it can get confusing. In undetermined significance, if the age is less than 25 years, less than 25 year undetermined significance, okay, baby got HPV infection, but they, within 2 years they are likely to resolve. So we'll follow with yearly PAP. If your PAP is your primary screening modality and you get ASCUS on that, if age of the patient is less than 25 years, you can follow after 1 year. Each year you can do PAP. If on the next PAP it comes normal, then you can follow every 3 years. If again it comes as ASCUS, then again you can follow. So you can see it like that, and you can do additional tests. You can do HPV testing or something like that. If LSIL is the finding and age is less than 20 years, again same. It's a low grade lesion. You will follow yearly. If age is more than 25 years and you are getting LSIL, you have to do colposcopy. You have to see under a magnifying. Colposcopy is actually a magnifying glass only, and you have to see what's going on, and if you see there is some suspicion, you have to take biopsy from that. So that if you get ascus H, which is high grade, anything H high grade, you have to do colposcopy. So basically rest everything. Also ascus as if more than 25 years, so you have to do HPV. You have to find out whether these changes are because of any HPV presence. If not, then you can just follow PAP. If HPV is positive, then you have to do colposcopy. Again, ascus as you had done less than 25 years, again after 1 year you had called her and it comes ascus. You will do HPV testing. If it's positive, you have to do colposcopy. So you have to follow this algorithm if pap smear is your primary screening modality. Now second, if your HPV DNA is your primary screening modality, if it is negative, you can just continue screening. Like I told you, 3 to 5 years you can repeat. Mostly we do it every 5 years. If it is positive, you can go for treatment. Now if it is VIA, I had explained you the see and treat approach. If you can see a lesion, you put acetic acid, you can see a lesion, you can go based on the VIA approach that I had told you here. Wait, I'll tell you. I did tell you VIA, right? So VIA, if you see there's a lesion, you can just go ahead. You can use you can do either cryotherapy. You can, if it's cryotherapy criteria is met, or you can go for other treatment modalities. But if you're seeing a lesion, you might as well just treat it. So VIA is basically used in settings where they will come to you and you will not wait for second screening for them to come back again. If you're seeing a lesion, if it is abnormal, you will treat it right then and there. And like I had told you, on VIA you can take biopsy also, so that's possible. Now WHO recommendations is you start screening from 30 years to 49 years is the range. If HIV is positive, you can start at 25 years. WHO says you stop at 50 years if previous decade is normal. Also, you have to remember that according to WHO, VIA is a very good method. HPV anyway we are not doing in India, VIA. And in VIA you cannot do beyond 50 years. In postmenopausal women, the transformation zone goes inside, so you can't do beyond 50 years. So it says you stop at 50 years if previous decade is normal. Okay? Now method usually it recommends you do HPV DNA and VIA every 5 years. You do only HPV, you can do it every 3 years. VIA you have to do every 3 years, or cytology. So it mainly prefers these two methods. But if it's not possible, in India we are not using HPV kits because they're not standardized, we go with VIA. Now see and treat approach, or you can call it screen and treat approach. If, like I said, you're using HPV DNA, VIA. If HPV DNA is negative, you repeat every 5 to 10 years, or if it's HIV positive ladies, every 3 years you can continue. Yeah, like she has HIV and she also has, she does not have HPV. So every 3 years you can do screening. In HIV people, we have to screen. In people with retroviral disease positive, we have to screen little faster, and otherwise in normal population, general population, you can do 5 to 10 years. If HPV is positive, you have to treat based on the VIA support. So if the criteria for cryo is eligible or not. For cryo, the lesion should be visible, it should be outside, you should be able to demarcate it. The cryotherapy machine that you use, it should fit it. So there are certain criteria of using cryotherapy. If it is fulfilled, you can treat, and if it's not fulfilled, you can go for loop excision. Okay. Now if VIA is negative, you have to continue screening every 3 years. If it comes positive, agar cryo is possible, yes, if it's possible, you do cryo, otherwise you do leap. The basic thing is, when you have VIA, or according to in low resource settings, or in settings when VIA and HPV and LEAP and cryo are the only possible options, if HPV is positive, you will treat, because you're thinking that okay, the patient has some disease, will likely get in pre-invasive cancer after 3 to 5 years, you might as well treat now only. On VIA, if VIA is positive, you're seeing something, why will you follow it up? You might as well go ahead and treat it. So you're screening and going ahead with treatment. Treatment is cryo or LEAP. Cryo you will do if the criteria for cryo is fulfilled. Okay. Now second is C, triage and treat method. In this, like I said, PAP is not so much recommended by WHO. HPV is primarily recommended if it is positive. If HPV is positive, you can do a second screening method. Triage means, first you will see screening method. This is the screening methods. Then second triage methods you will use. It can be the genotype of the HPV. You can take a PAP, you can do a VIA, you can do colposcopy. I will come to this cycle later. If HPV is negative, 5 to 10 years you can continue in general population. HIV positive population every 3 years. Okay. Now this Foxy one will come later. I have explained it to you before only. Okay. So what will happen is, if HPV, if you do high for this HPV positive people, and you're doing triaging test also, second test, if you do genotyping in high risk HPV is positive, then you'll go ahead with treatment. If PAP you have done, and on PAP, like I said, you've done PAP, on PAP if it comes ascus, okay, HPV DNA was already positive, you will go ahead with colposcopy. If VIA you have done, okay, and after this you do VIA. On VIA, if you don't see anything, you will follow maybe because it is HPV, you can follow a little earlier, every 1 year you can follow. But on VIA, on PAP, if you see any of these, on VIA you see a lesion, you go ahead with colposcopy or cryo. If you're doing colposcopy, then based on, you can take biopsy or treat simultaneously. Now if PAP is positive, you have to triage. Okay? Triage, how I'll tell you. If it is ascus, PAP is showing ascus, you will do HPV DNA. If it is positive, you will do colposcopy. If it is negative, then every 3 years you will follow up. On triaging, if you get anything more than us, you get H, LSIL, HSIL, you will go ahead with colposcopy. Triaging means you are using a second test and this is showing something high grade, or LSIL or HSIL. You will go ahead with colposcopy. So the whole point is, on HPV, with HPV you will triage with IH, VIA, PAP, and if it is negative, you will follow up every 2 years and every 1 year for HIV positive. I hope I'm clear. So this was I hope I didn't go very fast. I'll just tell you very briefly what I meant by this. According to WHO or anything, you have a primary screening. Okay? That primary screening you do, if that is negative, you follow up routinely. I'm not explaining again. General population is 5 to 10 years. HIV population is every 3 years. Also depends on what method you are using. If you're using a PAP, you can use every 3 years. If you're using HPV DNA, which is recommended by WHO, then you can go every 5 years. If you're using VIA, you can go every 3 years. So this is, I'm just writing follow up. If it is negative, you follow up as per screening modality. Okay, agreed? Now, if this primary screening is positive and you are in a low resource setting, low resource setting, what you will do is you will treat, because the patient might not come for next follow-up. You might lose this patient and later she can come with any cancerous lesion or something. So if you're seeing something, you might as well treat it. And in low resource settings, treatment you have either cryo or you have LEAP. Both are OPD procedures. You don't want to admit the patient, you don't want them to wait. So if cryo criteria fulfilled, you will do cryo. If not fulfilled, you will do LEAP. Simple. Okay? Primary screening can be your PAP. I will go and follow. VIA is recommended. Can be HPV DNA. Can be PAP. Okay? PAP becomes a little different. Okay, let's keep PAP out of this. We are just seeing HPV DNA positive, low resource setting, you treat like I described here. HPV positive, you treat. Negative, you continue screening. HPV positive, treat. Supporting criteria, you cryo. See, for HPV also you have to do VIA. If HPV is positive and you're going to do cryo or LEAP, you will invariably will be doing VIA, because you have to visualize. So that will be done. So that's not part of screening here. That becomes a part of treatment. Understood? Then screen, triage, treat. Here you can afford to call them for second screening, or so they can come. It's a good resource. So first screening, if it's negative, you will do routine follow-up. Primary screening with. If it is positive, you will use second. So if you're using genotype, high risk HPV is positive, definitely you will treat it. How will you treat it? You will visualize and either cryo if criteria is fulfilled. Criteria is not fulfilled, you will do LEAP. Then you will have VIA. Same. VIA negative, no problem. Routine follow-up. If HPV high risk is negative, you will follow up in 1 year. Why? Because most primary HPV infections are likely to resolve. If you have done HPV beforehand, they're likely to resolve. Negative, you'll do follow-up based on your screening modality. Okay? If VIA is negative, you do follow-up. If VIA positive, again, you will treat, because you're already visualizing. If it's positive, you will either do cryo, you will either do LEAP. If we are using PAP, you have done PAP, and PAP comes ascus, undetermined significance. You can let it wait. So you can do follow-up. Okay, like I had described here. You can follow these patients up. Ascus. Okay. Primary screening was positive and you are getting ascus, you can follow them up. You do, after 1 year, you do a screening again, and if it's still ascus, then you can think about follow-up 1 year. If it is still ascus, then you can go ahead with treating it. But okay, that can be done. Or if it is more than ascus H, you have to treat, because it will likely progress. Understood? So this is the whole gist of the screen, treat, triage approach. In HPV, if you're triaging HPV, you can use, if you're using HPV as primary screening, VIA, PAP, and if it is negative, you can just follow every 2 years and for 1 year in HIV positive population. I'll just tell you the WHO screening charts also they have given here, so that it's easier to understand. So like I said, if you're using cytology, if it is normal, you can rescreen every 3 years. If it comes ascus or greater, you have to do a colposcopy. By treatment, if colposcopy is positive, you can take biopsy. Okay? If you're not taking a biopsy and if it is eligible for cryotherapy, you will do cryotherapy. Not eligible, then you will do LEAP. If colposcopy is negative, you can rescreen every 3 years. Okay? Then if you're suspicious for cancer, you have to go for the cancer etiology. Biopsy may be what comes on biopsy. See, biopsy will be histologically proven. Then it will not be LSIL, HSIL, whatever. It will be CIN1, CIN2. If it's more than CIN2, you can see the post-treatment of CIN, I'll tell you later. Okay? Then this is for HIV positive women. Okay. Now this is HPV test. Okay. So I hope this first for cytology. And if you're doing HPV testing, if it's negative, you can re-screen after every 5 years. If it is positive, you do a colposcopy. If colposcopy positive, you can take biopsy. If colpo is negative, you can reskin every 3 years. Suspicious for cancer, you follow that guideline. Okay. If you're doing VIA is negative, rescreen every 3 years. If it is positive, eligible for cryotherapy, you cryotherapy use. If not eligible, you treat with LEAP. Post treatment, you follow up every 1 year. If suspicious of cancer, you do that. So VIA is the modality that we are advising. WHO is saying you have to do. If HPV testing is there, then you have to follow this. And if cytology you are using as primary screening, this is what you have to do. Now see, some of you will think colposcopy is it secondary screening. Ideally not. The whole point of doing a colposcopy is you know that something is abnormal, so you invariably want to treat it. If it comes negative, then you are only following up everything. But if it is positive or suspicious of cancer, you're following the regular guideline only. Okay. Now this is an HPV positive women of this HIV status. Okay, so I hope this is all clear to you guys, and maybe we can later make like a simpler video or try to simplify it even further. So yes, please revise, watch all the 3 videos together. CIN, cervical precancers 1, 2, 3. These will be 3 videos, and in the next video I will be talking about what is colposcopy, and what to do based on biopsy findings. So what, like treatment of CIN, CIN2, CIN3. Okay, so have a good day. Thank you so much for joining me. If you like the video, like, share, subscribe, and yeah.